serum has been suggested.
I think we can ask those later on. Thank you, Dr. Grover. Thank you very much. We have the next speaker, Dr. Rajesh Sinha, who's a professor at RP Center, All India Institute, Delhi, and he'll be speaking on management of corneoscleral lacerations.
At the outset, I would like to thank the Trauma Society, Ocular Trauma Society of India, for having me here in this wonderful session. And I'll be talking about acute chemical injury, which is definitely a true ocular emergency. Because the idea is why it is an emergency, because if we deal it later, if we delay, then the sequelae that are formed because of the chemical injury, they create such a situation that you have to resort to multiple surgeries and still the patient does not get that kind of a gratifying result. So that's why we have to act rapidly. The common agents are acids and alkalis, and acid injuries may not cause that much of damage to the cornea, but the alkaline agents, they cause more of saponification of lipids, and then the penetration of the chemical is more, and that is the reason why they are more devastating. So the aim of management is, at the acute stage, is complete removal of chemical from the eye, whatever way you can do it. And then, of course, control the acute inflammatory reaction and prevent a sequelae, something like this, wherein you have to keep doing multiple surgeries and still the patient may not have a gratifying result. So prognosis, as I said, depends on the rapidity of action. That is the key. So the management can be considered in two different parts, actually: immediate management and then early management. So the first thing is that you have to remove the chemical. So that can be done by washing the eye. So irrigate the eye for 30 minutes. So or you have to check in the end the pH of the eye, of the tear film. So you keep washing, put a local anesthetic drop so that the patient becomes cooperative, then put a speculum, keep washing, and do a thorough washing, evert the lid, keep washing everywhere, and then after that you check the pH in the end, and the pH should be close to 7. Now the key is that if you wash the eye and check the pH immediately, you will definitely get 7 even if there is a chemical inside. So you should wait for 5 minutes and then check the pH of the tear film in the cul-de-sac. And particulate matter has to be removed by all means. So you evert the lid, you double eversion, remove the particulate matter, and even by conjunctival dissection, we have to do it. So as far as washing is concerned, whatever you get a tap water, wash it with tap water. Saline, wash it with saline. The idea is that you have to remove the chemical. There are studies in literature which have shown that balanced salt solution is the best solution as far as washing is concerned. But many times practically it is not possible, and you have to wash it. So do it even with the tap water, that will clear up. And then, of course, you have to promote epithelialization, and for that you have to see how much is the inflammation, what is the epithelial defect, how much is the limbal ischemia, how much is the corneal haze. All these things have to be taken into consideration, and then grade the severity of injury. Now, grading of severity is not just for documentation or for the purpose of academic purpose or so. The grading of injury is very essential to understand ourselves that what is going to the prognosis, because this grading has come up after understanding, evaluating thousands and thousands of cases. And that is why in grade 4, as you can see here in the Roper Hall classification, the whole group of more than half of limbal ischemia has been kept. Now you can have 180 degree, 190 degree also with same prognosis, and somebody who is having 360 degree ischemia also in the same prognosis group, which is not correct. And that is why Dua's classification, they divided the fourth group into three parts, and that is how they did it. So 6 to 9 clock hours, more than 9, less than 12 clock hours, entire limbus. So this is how they divided, and that is why studies have shown that Dua's classification is better in terms of explaining the prognosis and understanding the prognosis, what is going to happen after all the treatment. So after complete washing, we have to debride the necrotic material, then put the patient on drugs like analgesics, antibiotics, intensive lubrication, cycloplegic, and topical steroid. That is the key to reduce inflammation, because most of the collagenolisis that happens initially, it is basically because of steroid, basically because of the inflammation, and you have to suppress the inflammation. So suppress the inflammation, reduce collagenolisis, and increase collagen synthesis by adding ascorbate, etc., which will act as cofactor in collagen synthesis. So that is like doxycycline as well. So all these things have to be used in order to prevent damage and promote healing, promote collagen synthesis and epithelialization. Autologous serum and umbilical cord serum both have been found to be very effective in improving the epithelialization of the cornea in such cases. And as I said, that we have to remove the chemical. So even if the chemical is embedded inside, underneath the conjunctiva, we have to sacrifice some part of it. You have to dissect it, because if you don't dissect, don't remove the chemical, it will cause scleral necrosis in that area. And that is going to, cause complete damage to the eye. So that is why we have to remove the chemical completely, even after doing conjunctival dissection. And then whatever bare area is there, we can put amniotic membrane over it. Now, amniotic membrane has been found to be effective, not only for repairing the ocular surface, but also to reduce inflammation, and it acts very well in reducing pain in acute chemical injury. So that is why, if a patient has come immediately, remove the chemical, remove the necrotic material, look for all the particulate matter, remove it, and then put an amniotic membrane. That is very useful in promoting healing as well as reducing pain in these cases. So this is how some of the cases wherein amniotic membrane was used and the epithelial healing was hastened. And this is one study which was done at our center. This is the thesis candidate's name. This paper was sent and it was published. And we found out that amniotic membrane is really helpful in reducing pain and improving epithelialization. So there are multiple studies which have shown that AMT is really useful. Now, this is another procedure which was described again by Dr. Dua. He gave the concept of sequential sectoral conjunctival epithelectomy. So the idea is that you remove the conjunctival epithelium, whatever is coming up. If there is a corneal epithelial damage.
No, you can take your time.
If there is a corneal epithelial damage, and then there is chance of conjunctival epithelium to grow over it, conjunctivalization of the cornea. So if we keep removing it, then from the surrounding area, the limbal epithelial cells, they will multiply and they will take over. So that will help in better health of corneal epithelium. And then, of course, tenoplasty is something, or multi-layered AMG is something which is very useful. Now, in limbal ischemia like this, tenonplasty can be done. You can take it from the other eye and put it in this eye, and that really improves vascularization in that area and helps in conjunctival, in limbal ischemia. So, in conclusion, the management of acute chemical burn depends on severity. If it's grade 1 and 2, then you can just put lubricants, ascorbate, citrate, put steroid in the initial stage, let the surface heal. But in advanced stage, even in the acute chemical burns, after removing the chemical, you should use autologous serum or umbilical cord serum, if whatever is available. Autologous serum can be prepared from the patient's blood, so that is easier. And of course, amniotic membrane transplantation is very helpful. So the key to management of acute chemical burn is the rapidity of your intervention. That is the most important thing. And wash with saline, remove the particulate matter, assess pH after waiting for 5 minutes after complete wash, use corticosteroid in acute phase, and serum and amniotic membrane are useful. And the best thing, the whole idea of doing all this thing is to prevent the sequelae that can happen because of this. And again, most important thing is that mass education and appropriate legislation is something on which we should work, so that whosoever is working in the chemical industry should have appropriate protective gears so that the person does not get damage to the cornea. So thank you very much for your patient listening.
Thank you, Dr. Rajesh. I think your last slide was the best, the take-home message, especially for these acute chemical injuries, very nicely written. Just one question. Have you encountered any kind of corneal perforations in acute chemical injuries or anything? And if you have encountered, how do you manage it?
In acute chemical burn, unless it has not been managed in the immediate phase, unless the chemical has not been removed, there won't be any perforation as such. There will be inflammation, there will be ischemia, there will be epithelial defect, but there is a person comes to you in acute stage, the person does not have perforation. So perforation only happens if the chemical is left there, results in collagenolysis, and that results in perforation. So it takes some time to actually cause the perforation.
And what if the perforation has taken place and the patient hasn't really managed it properly by himself? So what could you give a couple of options?
Yeah. See, the first and foremost thing is that once again, if the patient has not been handled by anyone, and that is why it has resulted in perforation. So the first and foremost thing is to ensure that there is still no chemical in the cul-de-sac, in that area. So you have to check the pH first, then be sure that okay, there's no chemical. If the pH is on the lower side or higher side, then you have to once again wash it thoroughly. And in that case, one should avoid tap water, because tap water does have a lot of contaminants. So if you are washing at that stage, if there is a perforation still having some chemical there, then remove the chemical in an absolutely sterile manner. That is the key. Right. The second thing is that it depends on where is the perforation. More often, it can happen because if the chemical is there on the cornea, most of the times it can get washed even by tear film, etc. So if there is a subconjunctival thing, many times we see that there's some choroidal show coming up. So in that case, remove the chemical completely. If there's a choroidal show, in that case, it's better to do the conjunctival dissection, and one can put a scleral graft there, and also see that in surrounding area there's no ischemia. If there is an ischemia, along with the conjunctival graft, we can put tenon as well, so that vascularization also happens, and that will take care of it.
Thank you. Yes, sir, you can ask one question.
I am in the area of GIDC, that is industrial area, and I came across 2 cases of scleral tear along with severe caustic burn. So in that caustic burn, and then I did it, but that time it was showing scleral ischemia with perforation.
Right.
In that case, I sutured it, then amniotic grafting was used, and I did tenoplasty on that.
Okay.
Yeah.
And I did get 2 to 3 patients up till now in 5 years. There was a corneal perforation. I sutured it along with the routine treatment of chemical burns, and I did suturing. Then I inlay amniotic graft, and over that I put a BCL, just as a protection.
Right. Thank you. Thank you very much.
Just one point I would like to add. The only issue, sir, the only issue if you have a corneal perforation due to chemical injury, so what will happen that there will be tissue loss in that. That is the only concern. And if you suture it, then it will make it very, yeah. So I mean, if it's a such an emergency situation, then obviously you have to close the wound, and that is what you did. But better thing is, mostly, if it's a small perforation, glue can still work, can help. But mostly in such cases, what happens that it perforates, and plus the surrounding area which has not perforated, that is also sloughed up. So you have to remove all that and put a patch. That is, I guess, the best thing. But yes, in such situation wherein you don't have a tissue, you have to close it somehow. Yes, we can do a tenous patch. So that is very important. Tenous patch is something which is really helpful in ischemia.
Thank you.
No, just tell me, how do you manage the cases? Sorry. When they come with absolutely swollen eyes, it's very difficult to open the eyelids in an emergency. how do you manage to do washing and examining?
Put local anesthesia.
Yeah, and speculum maybe, you'll have to use a speculum.
You have to use, you have to use
You'll have
local
to-
anesthesia.
You have to.
Yeah.
Oh, well, maybe.
Yeah, I mean, that is also an option.
That
Because
is
if the
also-
patient is not cooperative in spite of the topical anesthesia and the lid is also swollen, that is a good option. You can use facial block and then retract the lid. You have to wash the chemical out, whatever way you can do it.
Thank you, Dr. Rajesh. Thank you. Thank you very much, Dr. Rajesh.